So again, altogether, this virus it's a mean little sucker. In certain ways, SARS and MERS, which have much higher mortality, SARS at 10% mortality, MERS at like 50 or 30%, and Ebola has 50%. A virus that kills more and kills faster is actually easier to control than a virus that kills slower, kills less, and spreads asymptomatically. So again, all these reasons why it's just so difficult.
Eric, welcome to the show, man.
Thank you. Happy to be here.
Pleasure to have you on. This must feel like a war zone for you at the moment.
Yeah, this epidemic, it's been raging. I think the world woke up to it somewhere in late January, but it's gotten really, really bad since. When we think it couldn't get worse, it's gotten worse. Like just yesterday, the total mortality, the total number of deaths outside of China actually exceeded the daily deaths inside of China. Like the curves have crossed. So now the epidemic is actually worse outside of China, and it's not stopping.
Man, well, I'm glad that I've got hold of yourself so that you can try and give us some signal to cut through the noise that everyone has been seeing online. I recently saw Shane Parrish is doing the same thing. He's got some coronavirus experts on. And the most common question that people are asking is to do with trying to work out where the bullshit ends and the information begins, right? So before we get started, who are you? Why should we listen to you?
Yeah, so I'm a public health scientist. I've been a faculty at Harvard for many years. And actually, I resigned my faculty to run for Congress, but that's a different story. But I really enjoy science communication and public policy and advocacy, and especially raising alarm about this. My doctorate was in epidemiology, so the science of epidemics. And although I did other chronic disease epidemiology, not infectious disease epi, it's still in my wheelhouse. And I think sometimes in the world, getting a message out there is something that many scientists are not good at. They know so much in their technical area that translating it for the world and making the masses listen is something that's not usually taught. And so it's something I really enjoy. And especially for this pandemic now, I think waking people up and waking them up early before the tsunami hits is something we have to do in public health, and we have to do way better. So this is why I'm tweeting nonstop about this COVID-19 and trying to make everyone listen.
I get it. Yeah, it's interesting that some of the people that are the best qualified to tell us the technicalities and the specifics about what's happening perhaps aren't the best qualified to communicate that out, right? And I get what you mean when you say about that. So, okay, let's start. What is coronavirus and what's COVID-19? Is that the same thing?
No, coronavirus is the family of viruses. It's like when someone who drives a certain brand of car, but they have different makes and models. Coronavirus is one family, and the common cold. There's a few coronaviruses that are common cold, but there's also common cold that's other viruses. SARS is a coronavirus. MERS, which is Middle Eastern Respiratory Disease, a couple years ago, also coronavirus. And it's one of those viruses that has these spiky, aura around it. It's corona. So it looks like it has a corona around the virus particle on the microscope. But it's an RNA virus, but it's not a retrovirus like HIV is. HIV is an RNA virus that has to convert to DNA, live in your DNA, merge in your DNA, and then replicate.
What's RNA?
Directly replicates its virus particles after it invades.
Okay.
Yeah, and so this is a virus that it made a jump from animals, but probably a bat or some other animal, to humans, and there's a lot of genetic evidence showcasing that. There's no evidence that showcases that or supports that it's a bioengineered bioweapon whatsoever. Because the more you go, there's these detective clues that you can see within the DNA, within the genome, the RNA genome, that suggests it was evolutionary driven, not as opposed to some human kind of insertion.
So that's the first myth busting there, that this is created by the Chinese government to drive the price of gold up or something like that.
Yeah. There's absolutely no evidence whatsoever. And there were some studies that, put out that idea in an unpublished preprint manner. I even tweeted about it because I thought, it's published, but it was retracted. And once it was retracted, I deleted as well. And that's all the thing. Like, there's a lot of there's bad websites, but there's also like these pre-publication websites that are not reliable because they're not peer reviewed, and anyone can publish onto them, and information is tricky. And I think people need a filter, and like putting debunking articles right after someone posts it. I think it's really key in this day and age. It's not bioengineering, bioweapon. Well, if there's no evidence to date about that.
Understood.
But at the point right now is, look, it's clearly a virus that's jumped from animals to humans. That's pretty clear. And we right now are just trying to focus on solving it. We can discuss and debate how it jumped later, but I think right now that's not the most important thing as part of the epidemic. Got you.
So are there different strains, or are we talking about one thing, COVID-19?
So strains, strange is like, there are different kind of branching, but all that branching evidence has shown that they all branched pretty recently sometime in November. So it was one single event that has since spawned all these different small variations. So there are like a variation here and there. Like, for example, the variation in Washington State is different from the variation that was in Iran. But we know the one in British Columbia that was tested from the woman who flew from Iran came from Iran. Iran came from Wuhan, while the Singapore and Japanese and Korean ones came from a different branching. And so using that kind of evidence, we can actually, instead of asking, where did you fly? You can actually look at the virus genome to see, where did this version come from? Like British Columbia, Vancouver is very close to Seattle, right? You think that maybe the Seattle version, the Washington State version is the same one. No, they come from different locations because of air travel. So you can actually, use detective work in its genome to see where it originally came from, as opposed to, just asking, where do you travel?
I guess it's useful, right? It allows you to see the footsteps of where this has been. Okay, so we know that about the different strains. What are the biggest misinterpretations so far that you've seen?
Besides those conspiracy theories, I think the misinterpretation, it's just a flu. That's actually early on, a lot of public health officials and policymakers just said it's just a flu. It's not just a flu because everyone has partial immunity to various strains of the flu. No one has immunity to this novel coronavirus, COVID-19. But the virus is called SARS-CoV-2. The disease is called COVID-19. The virus causes disease, COVID-19. It's an analogy is HIV causing AIDS, right? HIV is the virus, AIDS is a disease. So, but people just call it COVID-19. So this virus, I think the main misconception, first of all, is that it's just the flu, is very dangerous because we have vaccines for the flu. Each year, we may pick the wrong strains to put into the vaccine, but it's still at least partially effective, right? Anywhere from 50 to 80% effective against most of the strains. We don't have a vaccine whatsoever, and we don't have background immunity from you previously having the flu, for previously this virus. And secondly, the flu has a mortality of 0.1%. This one has a mortality of a full 1 to 3%. That is 10x to 3x higher, 10x to 30x higher. So they're not in the same order of magnitude mortality. Granted, there could be some places like Singapore with super high wealthy healthcare that could actually, the mortality could drop below 1%. But on average, WHO said it's 3.4% so far, and that's pretty scary, personally. So again, it's not on the same scale of flu. We don't have vaccine. We don't have countermeasures. So it's not the flu, and that annoys me to no end when people say it's just the flu. And also, finally, the other thing is the transmission. The transmission reproductive number, which means the R naught for every infected person, that person will infect, for the flu, 1.3 more people. For this virus, it's 2 to 4 additional people. If you think about it, that is one of the fastest exponential rises you can potentially find. Now, granted, there are things like measles that have higher R naughts in the teens, but guess what? We have a 99% effect of a vaccine against the measles. All you have to do is take it. So we, again, for something with no vaccine whatsoever, this is a very high R naught, and it has a doubling time around 1 week, which is a pretty fast doubling time in terms of transmission epidemic. So altogether, it's not the flu. In terms of other misinformation, some people say that men get sicker more than women. I would say that's partly true. Men get infected at the same rate as women, but it could be, but men seem to have a slightly higher mortality. But that's from a study in China, in which men, like 70% of men in China, smoke. And so if you smoke, obviously this thing is going to kill you faster. So is it because that it hurts men more, or is it because men also smoke more? We haven't figured that out. So I don't know if it's, and there's no genetic variation. I think, right now people are coming down in Europe, and people are dying in Washington State in the U.S., and they're not Asian whatsoever. So I don't think there's any racial explanation of why, there's no racial differences there. Yeah. And the other mysterious thing that is actually true is children don't seem to get sick from this. Well, they get infected and they get maybe a mild sniffle, but almost all children who are infected have very mild to almost no symptoms, which is in certain ways good, but very strange, but it's well established. And finally, the main differential between this virus and SARS and the flu is this SARS-CoV-2, COVID-19, is transmittable while it's asymptomatic. SARS, we were able to stop in 9 months without any vaccine whatsoever. This one, that's not going to be able to happen because, say you take a plane, right? You're healthy, get off the plane, 2 days later you get sick and develop your symptoms. Well, with SARS and many other viruses, it's okay. You only got sick 2 days after. We're not worried about everyone else that you traveled with. But for this one, it's tricky because you can actually shed viruses even before you have the symptoms. And so that is very tricky and very difficult for containment of an epidemic. Because how an epidemic works is that, how containment and quarantine works is that you find a case, you contact trace, and you quarantine them. And hopefully you quarantine enough, but based on a 7-day kind of thing, it's there's a lot of asymptomatic transmission that could have happened. So again, altogether, this virus it's a mean little sucker. In certain ways, SARS and MERS, which have much higher mortality, SARS at 10% mortality, MERS at like 50 or 30%, and Ebola has 50%. A virus that kills more and kills faster is actually easier to control than a virus that kills slower, kills less, and spreads asymptomatically. So again, all these reasons why it's just so difficult.
Got you. I want to loop back around to a few of the things you brought up there, but one of them is the current mortality rate, which you've said between 1 and 3%. I've heard and read some stuff talking about the fact that is the numerator that we've got on the top, but the denominator on the bottom, due to some testing questions, may be different. And if that numerator on the bottom turns out to be significantly higher than we've thought, because the reported cases in some places, the reported cases in some cases are people that are symptomatic or symptomatic, and the people that died from it are only people that died from it from the people who had symptoms, whereas it could be people who died from it versus people who were just infected, and that number could be much higher. Could you take us through that? So,
very good question, and epidemiologists have thought of that. There's two different things. There's a tug of war happening. What you're talking about is underdiagnosis. Basically, mild people or asymptomatic people, they're just not tested, and therefore they don't show up in the denominator of total cases, right? And this underdiagnosis, was a problem in China for a while, and it's still a problem in almost every country other than Korea. Korea is doing 15,000 tests a day, drive-through style.
What? Korea's got drive-through tests.
Drive-through tests and doing 15,000 tests a day.
Holy shit!
It is insane. Korea's you need a country that is like systematically, well managed enough centrally, and you have the wealth and you have the capacity for the scientific labs to do it. The United States can't even do that. The United States can probably, across all its labs, do only like 9,000, and that's across the entire United States right now at the moment. Hopefully we can do more, but our capacity is not even close to Korea. So my point is underdiagnosis. Oh, by the way, Chinese numbers are different than other numbers because if you test positive and you don't have symptoms, China does not put you on the confirmed case count. Everywhere else, if you're test positive, regardless of symptoms, you're a case count. So there's underdiagnosis, which if the number at the bottom of this case fatality ratio is larger, then the case fatality will drop in percentage, right? But there's another competing thing, and that is the mortality lag. So this disease is a long-ass sucker. Mild cases are about 80% mild to moderate, and the duration of mild cases is 2 weeks, which is, by the way, pretty long, because most people who have a flu just get over it in a week. But severe cases, which is 20%, severe and critical, 20%, is about 3 to 6 weeks long. And the critical people who are basically need hospitalization in an ICU, they have a 28-day mortality of 50% in China. And China, by the way, has a lot of ventilators. They can manufacture a lot of ventilators, and they have ICU staff nurses. But the issue is the 3 to 6 weeks. It means you have a lot of cases once they're diagnosed. Say someone's diagnosed during Valentine's Day after kissing. Terrible Valentine's Day. Mm-hmm. But their outcome does not resolve to a death or recovery for at least 6 weeks or 3 to 6 weeks. Do you see that? There's a lag. From the day that you have to think of a cohort. You can't think of it of mortality as simple back of the napkin calculation of deaths over cases. You have to look at it from a cohort perspective. And the problem is most countries, in China, still half the people have not recovered, And in Korea, I would still say like 80% of the cases are neither deaths nor recovered and, released. You've healed yourself. You don't have a virus. You're over it. Most of 2/3 of them or 3/4 have not been death or recovered, which means they're still part of this. I'm still sick. I still have symptoms, or I'm still testing positive. I've not cleared from my body. And that actually causes two problems. One, the lag, meaning this numerator is not finished, right? Is not this cohort, this Valentine's Day cohort of everyone who got on Valentine's will not be finished until end of March, early April. So we cannot finish calculating the case fatality then. If we just keep testing more, we're just adding more people to the denominator, but who have not finished the entire disease course. So there's a tug of war. Underdiagnosis would drag the CFR down, but the mortality lag of incomplete resolution of most of the cases, because they haven't hit the end, this case fatality is only finalized when everyone is either dead or fully recovered. And that has not happened for most cases yet.
Got you.
So hence they balance out to around 1 to 3%, depending on the model. And the other key implication of the disease being 3 to 6 weeks in 20% of the people, which is a lot. 1 in 5 people have a 3 to 6 week a disease course is hospital beds will be completely swamped. Like the United States, terrible. Like Korea has a really high per capita number of hospital beds, really high. Korea is like top 5. This is why China built a hospital in 10 days, right? And Korea, does not have enough beds, and most countries do not have enough beds, and it's just going to jam up the healthcare system. It's terrible in that sense.
That seems pretty ugly. Why don't you tell us what the virus does? What does it do? I've heard it's bad for people that smoke, and it's something to do with COPD. What is it? What's it do?
It's a pneumonia. It's a viral pneumonia. So it will give you a fever at first. You'll have coughing. That's common. And then you have, you feel like you have fluid in your lungs. You have trouble breathing. And over time, an infection can set in further of your lungs. And I'm not sure if it creates lung scarring. China did one lung transplant of someone with COVID-19, but it's unclear. You only need that if you have permanent lung scarring. And most pneumonia doesn't do that. But if the pneumonia is bad enough, you have problems getting oxygen. And that's why people are on respirator machines, because they need oxygen. And if it just causes really, really bad pneumonia, people just are oftentimes dying for lack of oxygen. That's the truth.
So we've said that children somehow appear to be fairly low in terms of symptomatic. Who are the people that are at the highest?
So I'm going to give you 2 answers. In terms of death, elderly definitely have the highest death.
65
the curve,
plus?
The curve goes up like this. It's not like a step. It's not a step function.
It's not a point.
Curve.
Yeah.
Yeah. It curves up. And it curves up starting around age 50. And then, definitely above 65, it becomes a high risk. Like in a nursing home in Washington State, there's been 6 deaths already in a nursing home of frail elderly people. It's really bad in just 1 week. But in terms of the other thing is, just because you don't die, actually, it's tricky. In terms of the healthcare system, I hate to say it, someone who dies quickly actually is cheaper for the healthcare system and for insurance. Someone who's sick for 6 months, for 6 weeks, that's actually really, really bad, right? Because it jams up hospital beds, ICU services, etc. And so I think you can't just look at death. And in terms of ICU, there was one study that says a lot of young people were actually stuck in ICU as well for this. It's, in terms of the earliest reports in China, there was just as many people under the age of 60 as over the age of 60 in ICU, presumably on the ventilator machines. This is a really serious issue because, look, people being sick for a long time is actually a really, really taxing thing on the healthcare system. And I think the other thing is, there's also many young Chinese doctors who've died. There's a 29-year-old, 34-year-old, 42-year-old. Like that's 4 doctors, like basically 40 or under. It's very troubling. So, and the other thing is, just because you're part of the 80% who have a mild and moderate case, you're still spreading it. You're not, most likely those people who are not tested are the 80%, but they're spreading it. And young people, old people stay home and watch TV or play checkers or something. Young people are out and about, going to work, bartending, waitressing, going to movies, sports games, going to restaurants. They're the ones spreading around. And so in certain ways, their morbidity may be less, but they actually add to the total number of people infected. So these infectious 80% mild is actually much harder to control because, again, even if 20%, only 20% get sick, these 80% keep spreading and amplifying the total denominator for people who can come down with something really serious.
Yep. That's
why I don't think just because it's mild for you doesn't make this virus any better for the general population.
I understand, yeah. So we touched on it there and you mentioned it earlier on. I really want to try and get some definitive ideas about when your infectious period begins, how long the onset is likely to take before you are either symptomatic or non-symptomatic, and then when you could release yourself into the world?
Yeah, good question. So this is actually a project that I'm working on, because right now, based on the early studies, and we don't have incubation times for everyone. Incubation is defined at the moment you got infected to the moment you develop symptoms. And sometimes you don't know when someone first got infected. So not every case has this information. For the limited numbers we have, it says anywhere between 5 to 7 days. But that means that's just the mean. Half of them are longer than that. And right now, all the quarantine rules are basically quarantine someone who was exposed for 14 days. You're traveling, entering the country, quarantine 14 days. The question is, there's a normal distribution, right? And if the mean is at 5 to 7 days, the question is, are you sure that by extending it to 14 days quarantine, you've captured the entire tail? Because what if this tail, centered on 5 to 7, has a very, very long tail? And let's just say 10% of the people exceed 14 days incubation. Which means, I'm perfectly healthy for 14 days. I'm going to be released on the 15th day. They could still develop it if they have a long incubation time on the 18th or 20th day.
Got you.
And then because the quarantine time is supposedly, if you pass this quarantine time and you haven't gotten sick, we can release you into the wild, right? You don't have disease, go have fun again. But the question is, I don't know if it's long enough. And there's some studies of showing someone with 21 days or 25 days or something like that. Now, I don't know if they're misreported, but it's concerning, because is 14 days fully capturing 99.9% of all people? Because if you just let one person out, that one person can have a super spreading event.
What's that mean? I've heard that term used before: super spreading and super spreaders. What is that?
Yeah, so on average, one person, I told you the R naught, one person affects 2 to 4, right? A super spreader is some unusual circumstance. It's one person is spreading to tons of people, 5 to 10 to 20 people. Like a super spreading event is like a sick bartender who serves everyone at a party.
Yeah.
And then that person does not just transmit to the average of 2 to 4, 3, but it's in spreading to like a whole party. And from there, it gets loose. And so that's a super spreading event. And the person who does it is a super spreader.
So it's nothing to do with someone's particular physiology or the strain of the virus that they've got. It's more to do with lifestyle and the way that they interact.
Unusual circumstance.
Got you.
So there was another super spreading event years ago in the first SARS epidemic, in which there was a toilet system in a Hong Kong building, and the toilet system was outgassing septic gas, and which held the virus particle, and it went to the ventilation system and went into infected the whole building.
Holy fuck! That is a bad thing to have happen.
I hate to say, there's a study that basically, now it's not of this new virus, this is too new, of the old SARS virus. Someone did a study, and they realized that obviously you can spread it from a droplet, sneeze, right? Or talking at dinner time to someone. But apparently it's also in the fecal matter, which means, and they did a study of flatulence. Is the virus particle in the flatulence? And the flatulence, it can go pretty far. Now, I wouldn't say this on camera on TV, but we're a podcast. So.
Yeah, we are. We can say whatever you want, Eric. Let's start to debate about whether or not we can fart our way to a pandemic.
Yes, it is. I will send you the link. It is. Someone did a study. They should win, the Nobel for this. But they actually showed that the virus particle can actually travel quite far if you leave a very, very long trail of farts. So now it's not for this current virus, but it's for the old SARS virus. It's a sister coronavirus.
How likely is it that it's going to have the same capability?
Yeah, I think it's likely, because there was issue in Hong Kong last month as well. And someone was self-quarantined at home, but someone was living like several floors beneath them got infected. And they found that it was also something related to septic gas.
Got you. So we've spoken about the fact that it's to do with, at least mostly, droplets. I've heard it's something to do with it's not airborne, but like waterborne. What does this mean? How do I get it?
It just means like a lot of these droplets, when you sneeze, like achoo, it actually goes pretty far. It doesn't have to be fully airborne. Now, there's some argument that it could be airborne. I think the jury is still out. So
what's the difference? What's the difference between airborne and water droplets?
Well, water droplets will eventually settle, right? Airborne means like it will stay in the air and will float in the air like a balloon, right? Well, obviously a tiny particle, but stay in the air. But a droplet means these tiny things like when you sneeze or when you speak, it comes out of your mouth, but over time it will settle down. So it's like flying in the air for a short distance. And so we're sure about that. Now, fully airborne, it's hard to say. There's some study that says yes, some study that says no. But I think the main thing is close contact. And I think the close contact issue, we've seen it also. We think a lot of for example, the Diamond Princess ship, it was a petri dish literally to grow. And a lot of people, 1 in 5 to 1 in 4 people on that ship has tested positive, which is insane. That ship has 3,700 people, and 1 in 4, 1 in 5 people has tested positive. And the reason we think of that is because a lot of the people who are in the inner cabins, besides the food sharing and public, but people who are in our cabins, they don't have like a window, and so their ventilation system. Now, is it airborne, or is it like droplet travel through the system?
Okay, so we let's say that we're with someone, we're talking to them, we've got that concern. What about if I touch my mouth and I've got it, and then I put my hand on a doorknob or something? How long can it live on a doorknob?
Yeah, it can live a week.
A week?
Yeah, week.
That's a long time.
Yeah, it's up to a week. It depends on certain things like temperature and humidity. It degrades faster in warmer and more humid air. But at the same time, we're not like Singapore epidemic. Singapore is 70, 75 degrees. That's like 20, 25 degrees Celsius. And so that still happened. But the thing is, we're mostly indoor people. Singapore epidemic happened. The super spreading event was at a Grand Hyatt Hotel Singapore. And that hotel, hotels, it doesn't really matter what the outside climate is, right? If you're at an indoor conference center or indoor gym and you get it, it doesn't matter what it is outside. So, I think one of the misinformation actually is about, it's going to all go away when the summer comes. It's going to be too hot. Except we are indoor workplace kind of people. And there's something called the southern hemisphere of the Earth, and then it'll just go to in Africa and Australia and Indonesia when it's wintertime in the summertime in the north and the wintertime in the south. So I don't think that it's going to go away in the summer. Arguments, it might slow down a little, but it could easily come back in the fall.
Got you.
That's the tricky part. The virus seems to be a survivor, basically.
Can containment work, or are we just past that step now?
Containment, a lot of people say WHO is still trying to be optimistic that containment can work, but I think we may have to move from containment to mitigation.
How do you do that? What's the difference?
Mitigation is just reducing the number of people who are exposed. You test as much as you can, but in terms of actually stopping the virus, you mitigate its impact, and you mitigate its spread. But containment just means preventing a community transmission event, right? if someone travels from, say, Iran, lands at the airport, and then we detect that they're sick, and we quarantine them, then that is contained, right? But if they can't come back, infects their kids, goes to daycare, childcare, goes to a party, infects everyone, and they all go home and they all test positive, and they all don't know necessarily where they had gotten it, it's not contained anymore. It's community transmission. And community transmission is way more dangerous than a travel-related thing, because it means they picked it up randomly in the community of an unknown source that we can't necessarily trace anymore.
Got you. Okay, so when does it get to the point where we need to just buy all of the rice in Costco and not leave our house?
I think depending on which country you are, we're already there.
Is that realistic? Do I need to do that? Like, I don't think there's any cases in Newcastle where I am. Like, should I be worried about going into a room? No, I said
depending on where you are.
Yeah.
I don't think the UK is there. I think Italy is there.
Italy's having a bad time at the moment.
Italy is so bad. Italy really is bad. Seattle right now is having a really bad one. The Seattle area, Amazon has many buildings, but one of their buildings that does Amazon Fresh and Amazon Prime Now, it's called the Amazon Brazil building. It holds like over 3,000 workers in this huge building.
Wow. Someone
tested positive on February 25th, and they had to send a notice to everyone. And the epidemic is so bad, widespread in Washington, that I think they may have to shut down schools soon. They might have to cancel all public events. Like some places, you have to put these moratoriums on public gatherings. And I think some places, like Italy's already done. Italy just canceled schools today for like at least 2 weeks, maybe longer.
Yep.
Nationwide. I think Washington State may have to do that as well.
Dubai already has.
Yeah. No, but I think this is where, mitigation comes in, because you're not containing it anymore. It's there. We just have to, lock down people. And it does work. Social distance, until we have the vaccine, which will take a year to 18 months, a year if we're lucky. And hopefully the vaccine is high enough, like a 60-70% effective vaccine might not be enough to stop this virus. Remember, for every infected person, it may infect 2 to 4 additional people. So you need to get the R below 1. And so with that, something that has, say, R of 3, you need like at least 70% higher just to bring it below 1. Mm-hmm. You need a very high, you need 85, 90, 95% efficacy. And not every vaccine has the perfect efficacy like that. So, and then that is only a year and a half. There are existing antiviral drugs that could work. We're testing this. There's some older HIV and hepatitis C drugs we're currently testing. The drug does exist. It's been phase 1 tested, but we have to phase 2 test whether it works with this virus. Again, that might take 6 to 9 months. We could get early results depending on how good it is in late April at the earliest. So we'll have to see.
I get you. Okay. How can I tell if I've got COVID-19 without going to hospital? Where I am, hospitals might already be over capacity or whatever. Yeah. How do I know?
Because the symptoms are very non-specific at first. Fever, coughing, pneumonia. But there's many things that cause that, right? So you need to get tested. But at the same time, testing capacity is very limited. So again, if someone has something, it could be the flu. It really could. Or it can be another endemic common cold coronavirus that's not nearly so bad. You can't really tell until you're totally tested. You could get a CT, and it will tell you a CT will pick up a really bad pneumonia in your lungs, but that's more of an approximation. Again, it's not for certain. In Hubei, anyone who tested positive for CT pneumonia, they assume you have it, because that's because you're in Wuhan, right? Mm-hmm. The epicenter. But most you have to go through a test.
Okay. That seems like it's not as easy as it could be or should be, I suppose. Let's talk about the origin just for a second. I want to get back to how people that are listening can potentially protect themselves and then potentially some public policy implications as well. But there's been some talk. I've seen quite a bit of stuff about we need to find the origin. Patient zero is important. Is finding patient zero important? The person that it jumped from animals to humans?
At this point, it's not the most important thing at all. Patient zero would give you a source initially, but at this point, for all the treatments and containment and public health measures, it's of low importance. So people keep asking, was it the seafood market or not? I would say that it might not be the seafood market, only because the New England Journal paper actually found that the first 2 people infected in early December had no seafood market contact. It was only the next wave that had seafood market contact in late December. So it could have been that someone introduced it to the seafood market, and seafood market was like this super spreading event, right? But whether it was introduced to seafood market or it was made its jump from the animal to humans at the seafood market, it doesn't really make that much of a difference, I don't think. The only people who really care are the bioweapon conspiracy theories.
Yeah.
It's a moot point. We know that these there's tons of there was a study in which people studied how many coronaviruses are in bats. Oh my God, there's like dozens and dozens that we've never even known about. Mm-hmm. And so then they tested the blood of all these people, these indigenous people and local rural tribes are exposed to these bats, and they found, oh my God, these people actually have a lot of coronavirus that never been identified before. They've just been mild, and we've ignored it because it's not bad. But this one is actually a really bad one because it selected itself for, over time, the survival of the fittest in terms of viral evolution. So we have now viral evolution selected one of the most infectious, severe viruses. And it is perfectly natural and possible and plausible that it happened by itself.
Have we had any indication that this virus could mutate, and is that a concern? Does it matter, and what does it mean?
Yeah, so it can mutate. RNA viruses mutate more than DNA viruses. That's like a general rule, because RNA system is always a little funky because DNA has 2 helixes, right? And so if you make an error, the other helix realizes the error and something fixes it right away. The RNA is a single strand, so it doesn't have this correction mechanism. But the coronavirus is a big enough RNA that actually has a special endonuclease within it that actually can fix errors along the way. So it doesn't mutate as fast as the flu. The flu has a very funky mutation system that tries to always reshuffle itself and creates brand new strains every year that causes vaccines to always have to play a whack-a-mole catch-up. But hopefully we can have one vaccine that will work for this. It doesn't. So we haven't. We have different variations, small variations, and they found that the actual mutation rate is one mutation. Approximately one amino acid mutation every 2 weeks. So that's how they figured out. That's the approximate rate, and so you can figure out how it diverges. The detective sleuthing of the virus genome I told you about earlier. But it's not. We're not going to get multiple strains, and it could mutate, but at the same time, it could. Most mutations are just junk mutations. You could potentially select for a very hyper survival one, but generally you need a very high number of infections for that. And right now, overseas, there's still not enough of that. I don't think the mutation is our current worry. I think we will be able to find one vaccine that will work for it for a long time. It's not like the flu in that sense.
Got you. Right. What are some of the things that the people who are listening can do to protect themselves? What's the 80-20 on that?
I would stop shaking hands with people. No offense. Wave hi at them, fist bump, elbow bump.
I saw sorry for butting in here, but I saw a relative transmission rate graph, which I'm going to presume that you've seen, and it's like the elbow bump was best, then followed by the fist bump, and then there was like the slow fist bump. I'm like, who's doing a slow fist bump? Like you're from Saved by the Bell in the 1990s or something.
I think that's just one measure. I think the other key things are, just don't touch your face. By the way, really embarrassing. At Washington State, there was a press conference about the epidemic. And as she was fumbling through her papers, she was saying, everyone, wash your hands, don't touch your face. She was flipping her paper.
And licking her fingers to get through the bits of...
In the middle of the press conference, telling people don't touch their face. It was terrible.
What is it? It's not face palm, is it? It's like face.
Yeah.
You don't want a face palm. That's the problem.
Oh God, yeah, I know. Anyways, it's become an internet meme now, but it's just so terrible. But I think avoid touching elevator buttons. Just avoid touching doorknobs. I know that is really hard, but doorknobs are not disinfected often. Don't touch things in public. You have to kind of be a little germaphobe until this thing is over. And public transit is the other thing. Like I see like this, the city leaders are always saying public transit is fine, but public transit is also one of a confined space, limited ventilation. You know what I'm talking about. It doesn't have, unlike the airplane at least, it takes in new air every 3 or 5 minutes. So the air in the cabin is being replaced every 3 to 5 minutes. So in certain ways, the airplane is pretty good. Unless you get unlucky and sit someone next to a cough, the airplane is actually pretty good in terms of replacing the air. But that's not true on a bus or a train, And I don't know if they use super high, small micron HEPA filters that can filter out virus particles, because not every air filter does. So, I think the other key thing is people ask, do you travel? I say, look, at some point, once the pandemic becomes really real and it's like in 80,
what's that
90,
number? What's really real mean?
As in like the epidemic is literally everywhere. 80, let's just say if I was in the United States, it's in 80% of all the states, I'm going to say it's probably everywhere. And staying here is no better than getting on a plane and going there. Granted, airport is a place to exchange, but I don't think you should stop your life. And people ask me how anxious am I? On a scale of 1 to 10, I'm a 6. I'm worried, but I'm not anxious because I'm anxious about things that is something I can control that I'm not doing, right? Like testing. I'm anxious that we're not getting enough testing. But am I anxious for the inevitable? Because the CDC, one of the CDC vaccine immunology head says, and report to Congress, this virus is inevitable. It will be in every single state. In that sense, I am not anxious because it's like, just brace yourself, come what may, right? So I have that kind of stoic mentality. Mm-hmm. Obviously, not everyone does. Mm-hmm. But, protect yourself as much as you can. As for masks, surgical masks are pretty useless. And N95 masks do not filter out everything. But N95 masks are better. But at the same time, if you wear a beard, it's totally useless. If wearing the N95 mask, by the way.
Because you need full seal around.
Full seal around it. Again, the surgical mask, the mask, what they mostly do is it catches your spray from your mouth. When you're talking to someone, hey, how's it going? I have a great idea. And you're spraying, even if you're someone who's very careful, everyone sprays their saliva when they talk. At dinner time, it's natural. But it does not actually protect you from inhaling the virus if in a tiny droplet in the air. Does that make sense? So, sometimes people have a false sense of security when they wear a mask. It's not. It's to actually protect others, not to protect yourself necessarily.
Okay, that's not good. I thought I could just stick a mask on and I'd be okay. So it turns out that that's not very good. So what about helping?
N95 masks are partially effective. They are partially,
but they're also now in the highest demand. No.
Yes.
Getting hold of. Have you seen? I just got told before this by one of my friends that alcohol hand wash prices, like some companies charging like 10x, 100x what it should be.
Yeah. No, there's a lot of price gouging. Although there's actually like do-it-yourself like home hand sanitizer that you can make out of isopropyl alcohol yourself. So
okay. That's cool. That's pretty cool. People be able to search on the internet and find out how to make it.
Find out how to make your own hand sanitizer. It's probably shelf life stability, probably not as good, but you just mix some aloe vera gel and this alcohol, and you can. It's good enough.
Cool. That's a really good tip. I like that. What about ensuring that I am as robust as I can be? Should I be upping my vitamin D3? Should I be,
Yeah, some people say take your vitamin C, vitamin D, and vitamin D is good for general immunity. Vitamin C can maybe, shorten a cold to a small amount, but we don't have evidence. I'm a scientist. I'm an epidemiologist. I also do clinical trials. Unless you have causal evidence, the jury's still out in my sense.
Probably no harm in doing it, but there's also no indication that it's going to move the needle.
But don't go panic buying on these things without evidence. Okay. That's my general thing. Don't go panic buying. Also, by the way, panic buying is more of a somatoformic social phenomenon. If you see someone panic buy at the store, you're going to panic buy. But if you see someone just buying one or two, you're just going to buy one or two, right? It's the panic buying is you see other people panicking and then you panicking. And then that's how stampedes happen. That's how people die in stampedes, right?
Yeah.
Because oftentimes it's other people running and so all of a sudden you have to run too or else you're going to be trampled. So society is a funny little place.
Yeah, man, it is. These weird shaven apes walking around with a brain that really doesn't work right for the environment it's in. I got a couple more questions. First off, we've spoken, it's been in the nicest way possible. Eric, you haven't told me what I wanted to hear. But I'm glad that you've told us what you know. What would be an indication, two-part question. First part, what would be an indication that things are getting worse?
The indication that it's getting worse is if the epidemic is unchecked, even in a high-income country like Germany, Sweden, Finland, Denmark.
What does unchecked mean?
Like community transmission, like really fast community transmission in those kind of places, I would really start to worry, because those places have some of the best healthcare systems. And the other signal is in Korea, if the mortality, how I talk about the cohort, your Valentine's Day infected person, by the end of March, if the mortality is still pretty high, then I'm gonna still be pretty worried about it, because if the mortality is like above 1%, even in Korea, that's pretty bad in my sense.
Got you. Okay. What would be an indication that things are getting better?
The community transmission stopping, and I want to see a high number of tests. And then high number of tests, the proportion infected steadily declining, assuming the same constant number of tests. That would be a good signal, because the more you test, or at a high test volume, you're not finding more. That means potentially the epidemic is winding down. I just want to say that the test is not perfect. The test has a accuracy about 50% or less, which means not that there's false positives. If you test a positive, it's most likely pretty much clear it's positive. There's a lot of false negatives. And the false negatives is not an issue when you're first diagnosing a case as much. Early on, it's really important to catch every case, but at least catching at least 50% of the cases is better than catching none, right? The problem of this high number of false negatives is that when it's time to release people from either quarantine or from the hospital, their fever's gone, their symptoms are resolved, and right now, oftentimes, you need 2 consecutive, 1 full day apart, negative tests, 2 consecutive negative tests. But the problem is you can easily have, 50% times 50%. You could have a 25% chance just by pure luck that you get negative tests, right? And that worries me because
this person's now out there spreading it around, thinking they're fine.
And because there's many examples, someone tested negative 7 times, released, tested positive a week or 2 later.
That's an actual example.
Oh my God, there's like 5 or 6 examples in China, in Japan. This happens so many times. Just look, right now they call it reinfection. I don't think it's reinfection.
It's misdiagnosis.
It's just you were released based on negative tests that are faulty.
Got you.
And then over time, say you get sleep deprived one night and you had a stressful day, and then your immune system drops a little bit, and then the virus flares back up.
Got you.
But you never shed it. Like this happens all the time. Like for example, HIV. HIV tests, sometimes they say, oh, the drug was so effective, it is below the limit of detection. We can't detect the virus, but we know it's still there. So this kind of thing happens all the time. Like you could be low, and the test will give you a negative, but the test might not be sensitive enough to the super low. And 2 negative tests to release you still have it, still shedding, test positive later, but during that time you may have infected someone. That actually is what worries me the most. I would love to see a test with both high sensitivity and high specificity. Sensitivity means all the true cases, how many do you find? You want to find 99% of them. High specificity means all the people who don't have it, how many percent that you correct, like 1 minus the false positive. So a false positive is 1%, the specificity is 99%. You want the specificity, you have a test that have high sensitivity and high specificity. And oftentimes the problem with the US testing delay was the kit. There was 3 parts of the kit. The first 2 was to find the virus. The third was a negative control. The negative control had a whole bunch of other miscellaneous viruses. And the test kit was supposed to test positive just for the COVID-19, the SARS-CoV-2 virus, but negative for the negative control. But it somehow cross-reacted, and the test kept testing positive even for the sample that does not have it, because somehow the test is picking up other viruses as well. And that's why the testing in the US was delayed 2 weeks. But this testing problem, we need to get a better test. But this 50% accurate one and 50% based on Chinese Academy of Science analysis is currently the best we have, but hopefully we can find also a more rapid one. Because right now, the lab, the PCR, you need a PCR machine. So it takes at least 12 hours to, by the time you send it to a lab, get it back. And it's pretty labor intensive. If we have like an A1C, like a glucose strip or cholesterol, you basically pinprick, stick it in the little strip, and it tells you, or something rapid under an hour, that would be really great. There are people working on it, but it still has to go through some approval. But and then I want to see how accurate it is.
Man, I can only imagine some of them. I mean, you're one of them. You're one of the people that's in the midst of this particular situation. But I can only imagine how chaotic some of the guys working at vaccine laboratories, working at the testing laboratories, working at the control centers, and then take it one step up from there. What about the doctors, the nurses that are working? It's like every healthcare professional on the planet just got turned up to 11, right?
Yeah. It is it is really stressful for healthcare professionals and also first responders, like firefighters and police who first respond to someone who falls ill and needs 911 or emergency ambulance. And unless you know that this person has a respiratory illness who could be a potential case, you're not wearing any protection. And the scary part is, look, the Japanese quarantine officer who boarded the Princess Diamond ship, the one that was quarantined off of Yokohama, he boarded with mask, with protective gear, did inspection, got off the ship, tested positive. Another firefighter in Japan transporting these patients as they were evacuating, he was wearing protective gear, finished transporting, tested positive. And so it's really trouble. Like right now, in one county next to Seattle, Washington, 25 firefighters have been quarantined, which is a full quarter of their entire firefighting workforce, out of commission for 14 days. And now half of them have developed flu-like symptoms, all from just transporting, there's one patient. This virus is so infectious. It is just, you cough and sneeze and it goes everywhere. And that's what's such a worrying little sucker.
Yeah, I get it. So I want to wrap back up and just give everyone what they should take away from this, apart from obviously all the information. And thank you so much for giving us your time. I know that you must be crazy busy. You're on Turkish TV and Iranian BBC and ABC and all this stuff. The things that people can do, what should they do? Give us the principles they should take away.
Don't panic buy, slow buy. Your stock up probably like 2 weeks worth of food and water. In case of future panic buy. But remember, you're trying to prepare. So part of preparing is slow buy. Avoid touching people and avoid touching your hands. Wash, just generally going to restaurants, be very careful. Don't touch anything, basically. That's not purely, static clean. I would avoid social things. I would avoid concerts, sporting events, parties with poor ventilation, maybe outdoor party, but knowing and seeing how infectious it has been on so many different situations, avoiding these kind of things at all costs.
Public transport.
And public transport, be very careful. Be very careful. If someone coughs next to you, move out of the way. But at the same time, don't be racist that, someone just because they look like they're from China. At this point, looking like you're someone from China is not an indicator of someone having a virus anymore. Honestly. In that sense, avoid Italians, but that doesn't make sense either.
I get you. Yeah.
I think just social distancing is the most important thing. I hate to say it. Until we have these drugs or a vaccine, social distancing is really the best measure. And again, fist bumps and elbow bumps or something like that. Mm-hmm. Just avoid touching people. And even at dinner, if you're having face-to-face conversation, stand as far away as you can. Mm-hmm. And at restaurants, be very careful when you're going out to dinner and you're talking. Your saliva will naturally go into someone else's food across the table.
I get you. So, and if you're going to do a podcast, do it over Skype like this.
Yeah. Although someday we're going to have these virtual reality kind of like holograms, and then it's going to feel real because then you can.
If you can infect me with COVID-19 through a hologram, then technology's gone too far.
Hey, I have an infectious personality. Isn't that enough?
I get it. Eric, man, like I say, thank you so much. You are right in the midst of it at the moment. People want to follow you for updates and stuff. Where should they go?
Yeah, follow my Twitter. I have a Facebook as well, but right now I'm just purely on Twitter for this update. It is at Dr. Eric Ding. Dr. Eric, ERIC, then Ding, D-I-N-G, at Dr. Eric Ding.
Fantastic. Are there any other than your Twitter feed, obviously, are there any news outlets or websites or whatever that you think are giving accurate updates where people could follow those as well?
I think Stat News is a really good one. Stat News is like a healthcare newspaper. They have pretty good updates. Obviously WHO has updates, but WHO their recommendations are much more optimistic. If you want more realistic in certain ways or more predictively ambitious, I would say, following Twitter COVID-19 hashtag, it's a really good hash because it's something that everyone's using for this epidemic on Twitter. Anyways, I try to source everything that's directly sourceable from a journalist or a newspaper. So I'm trying to stick to the facts, but I'm giving the realistic things that the health department people don't necessarily want to say out loud. So
I think certainly in the environment that we're in at the moment, it makes a lot of sense to err on the side of prudence rather than optimism with something like this, right? Look, Eric, man, thank you so much for your time. I hope, in the nicest way possible, I hope that we don't need to do another episode about this.
I hope so.
Next time, if we speak again, we can just be talking about, something cool. Isn't that virus that all gives us like really, really good skin? Isn't that like such a wonderful pandemic for us all to have?
As opposed to, how much food do you have left next time we're in our bunkers?
Well, I do know where you are. If I need to contact you, and like I say, if so, man, it's I'm glad that I've got hold of someone who understands what's going on. I'm sure that a lot of the people that are listening do as well.
Thank you so much, and let's chat again, hopefully in a couple weeks or months.
Okay.